everyone. My name is Punishi Parekh, and I'd like to welcome you all to the Pediatric Masterclass. The main aim of conducting these sessions on pediatrics is to discuss the common pediatric cases that we encounter in our day-to-day practice. Along with that, we'll also discuss how to take history taking, how to do examination, how to approach common diagnosis in pediatrics, and most importantly, we'll also ace our skills on case presentations and how to answer your viva questions in your practical exams. So the main aim or the agenda behind taking these sessions for you guys is so that at the end, once we are done with the discussion, it's going to be like a one point resource that you can refer to when you want to revise your practical pediatrics. And also, we'll be discussing a lot of viva questions. So it's going to help you before your practical exams to go over these presentations once again. And I can vouch for the fact that if you're able to attend as many sessions as you can, then there'll be no doubt that you will not do well in your practical exam in pediatrics. So I can give you that guarantee. You just have to stick on and attend as many case series or as many case presentations as we take as we move ahead. And just a few points before I start today's discussion. Usually before every class, I tend to share the presentation beforehand so that everybody has it. You can keep it as a resource for you when you want to refer to it at the end. And whatever points that we discuss as we move ahead in this presentation, you can add it in the same PPT. So, you don't end up wasting time in taking down notes. And, I have your attention, undivided attention to this discussion. I encourage active participation and discussion from all of you. If you guys have any questions, any doubts as we move ahead, you're more than welcome to ask. We'll take all the doubts and questions at the end together, because what happens is I tend to miss out on questions if there are too many coming up in the chat box at the same time. So if you have any questions, you can note it down and we'll take all of those questions at the end of the class. And do not hesitate to ask any questions. If you don't understand the concept, you can ask me to repeat it once again and I can do that as well. But I really want you guys to get your basics and foundation really strong so that you understand the concepts and we start building pediatrics from there onwards. Okay, so the first set of sessions that we're going to take is on the cardiovascular system. And the first discussion today is going to be on approach to a congenital heart disease in pediatrics. So without wasting any further time, I will share my screen and we'll begin. Okay, I hope you guys can see my screen. Yeah, so we're going to be discussing approach to a congenital heart disease. Now, overview of this discussion is going to be classification and type of congenital heart disease. How do they present normally? A lot of common terminologies that we use or we often hear when we talk about a pediatric congenital heart disease. So we're going to understand what those terminologies are and what do they refer to. And lastly, we'll see the basic hemodynamic mechanisms of an example of a cyanotic and an acyanotic heart disease. So let's begin with the classification. So classification of heart disease can be broadly classified into congenital or acquired. What we're going to be discussing here more in detail is the congenital ones, but it's also important to know that you also have acquired heart diseases in pediatrics, the commonest ones being rheumatic heart disease, myocarditis, and Kawasaki. Other than these, you can also have other valvular pathologies, but I would say they are more common in the adults. So the common and acquired ones would be these three in pediatrics. Whereas let's look at the congenital heart disease. So the congenital heart disease can again be broadly classified into cyanotic and acyanotic. Now the question is, how do you remember these? Because it's so confusing. So an easy way to remember an example of the cyanotic congenital heart disease is the T series. Okay, so you have 5 T's. The 5 T's refer to TOF, TGA, TAPVC, TA, and TA. So TOF refers to tetralogy of Fallot. Remember, it's not Fallot. It's not, although the spelling is Fallot, but it's called tetralogy of Fallot. TGA refers to transposition of great arteries. TAPVC is total anomalous pulmonary venous connection. And the two TAs, minded it's not a typo. One stands for tricuspid atresia and one is truncus arteriosus. So these are the common 5 cyanotic congenital heart disease that you should know and you should remember. Because these are questions that can be asked you in the Viva that name some cyanotic CHD. So you should know these 5 T series. On the other hand, if we look at the acyanotic CHDs, you have the shunt lesions and the non-shunt lesions. So the commonest acyanotics that we see in our day-to-day practice or we see in our pediatric wards is usually VSD followed by PDA and ASD. So these are the 3 commonest acyanotic CHDs. But it's not that it's just these 3 shunt lesions. You also have others like coarctation of aorta, certain valvular pathologies, and last but not the least, cardiomyopathies. So your genetic cardiomyopathy or dilated cardiomyopathy, all of these also fall under the category of acyanotic congenital heart disease. But the commonest ones are going to be your VSD, PDA, and ASD. So again, these are questions that can be asked to you in your Vivas that name some acyanotic congenital heart disease. So if you name, say, ASD, VSD, PDA, they can ask you, do you know any other acyanotic ones? Then you should say coarctation, cardiomyopathies, because these are other common acyanotic CHDs that we see in pediatrics. Now moving ahead. So now we know that the congenital CHDs can be divided into cyanotic and acyanotic. Now, I'm pretty sure all of you have heard this term very often that it's a heart disease with increased pulmonary blood flow, or this is a heart disease with decreased pulmonary blood flow. Why is it important to know and why is it important to understand is because if you have to categorize and even give a differential diagnosis or come to a set of differentials for your treatment purpose, it's very important to be able to differentiate whether your heart disease is cyanotic or acyanotic. And again, whether if it's acyanotic, is it increased or is it decreased pulmonary blood flow? Similarly, with respect to cyanotic. The reason being because they will present differently, they will have different set of complications and they will require different side of treatment. Okay, so let's look at just what falls under each category, and then we'll see in detail what exactly is the meaning of this pulmonary blood flow. So PBF here refers to pulmonary blood flow. So when we're talking about acyanotic CHDs, you have 3 under the category of increased pulmonary blood flow, and those are your shunt lesions. So that's your VSD, PDA, and ASD. Whereas all the other valvular pathologies, coarctation, and cardiomyopathies fall under the category of acyanotic with either normal or decreased pulmonary blood flow. Similarly, when we look at the cyanotic CHDs, I know it's confusing to remember both. So let's find out a way of how you can memorize this. So if you have to categorize a cyanotic CHD, let's talk about the ones with decreased pulmonary blood flow. So your TOF and TOF physiology, let's not get confused with the TOF physiology. Let's remember TOF first. So your cyanotic CHDs with decreased pulmonary blood flow, the best example of this category is going to be your TOF. Okay, TOF also being the most common cyanotic CHD. Let's remember it that way, that if you have a cyanotic CHD with decreased pulmonary blood flow, an example of that is TOF, whereas all the other T series are going to be those with increased pulmonary blood flow. So that's an easy way of remembering how you categorize a cyanotic and an acyanotic heart disease on the basis of pulmonary blood flow. Now, why is this important? What exactly is this concept of increased pulmonary blood flow? We'll be seeing that in the next few slides. But remember, when I'm talking about an acyanotic heart disease, I'm referring to VSD because that's the most common acyanotic heart disease. And when I'm talking about cyanotic, I'll be referring to TOF because these are the 2 commonest in their respective categories. Okay, so keeping this in mind, we look at now what exactly happens in the hemodynamics of a VSD and the hemodynamics of a TOF to be able to understand why we categorize them as on the basis of their pulmonary blood flow. So let's look at a VSD. So what is a VSD? As the name suggests, it's a ventricular septal defect. What is a ventricular septum? This. So basically, this is your right atrium, right ventricle, and left atrium. This is the septum which divides the two ventricles. So it's the ventricular septum. A defect in the ventricular septum is known as a ventricular septal defect. Okay, now let's look at normal hemodynamics of the heart. What happens in a normal scenario when there is no VSD and it's a structurally normal heart. So all your venous return from the right side of the body, let's say that amount is X amount of blood. Okay, so that enters from your SVC, IVC, enters into the right atrium, tricuspid valve, goes into the right ventricle and enters the pulmonary artery. From there, blood goes into the lungs for oxygenation and returns via the pulmonary veins into the left atrium, goes down via the mitral valve into the left ventricle and exits through the aorta into the systemic circulation. So this is how your two circulations, your pulmonary and your systemic, move in series. Okay, so let's say this is what a normal hemodynamics of a heart looks like. Now, what exactly happens in a VSD? Now, carefully pay attention here. You have your X amount of blood coming from the venous return from the right side of coming as a venous return into the right side of the body. So it enters the right atrium, it enters the right ventricle, and it's supposed to exit via the pulmonary arteries. But what happens here is because you have a ventricular septal defect, there is a communication between the two ventricles. Okay. Now we all know that the pressure in the left ventricle is way more than the pressure in the right ventricle. And liquids, water, or similarly blood always tend to flow from an area of high pressure to an area of low pressure. And that's the reason why what happens is some amount of blood from the left ventricle, because the pressure is higher in the LV, starts shunting across this defect into the right ventricle. So what happens at the end of the shunting is that the amount of blood that is now in the right ventricle has increased, right? So it already has an X amount of blood which came from the right side, along with this extra Y amount of blood that's being shunted across the VSD from the left ventricle. So this basically VSD, a plain VSD will have a left to right shunt. Okay, so blood is getting shunted from the left ventricle into the right ventricle. And now the amount of blood that needs to exit the right ventricle to enter the pulmonary arteries to go into the lungs is equal to X plus Y. Basically, you have more amount of blood that's now having to exit the right ventricle to enter the pulmonary arteries to go into the lungs. So basically, when you have more blood which is now entering the pulmonaries, this phenomenon is known as increased pulmonary blood flow. As the name suggests, simply it means that there is more blood going into the pulmonaries and the lungs. And this is what is seen in a VSD. Now, if you look at similar lesions, like if you look at a PDA or if you look at an ASD, the pathology remains pretty much the same. So when you talk about an ASD, you have a defect in the atrial septum between the LA and the RA. So that amount of blood which gets shunted from the LA enters the right atrium, right ventricle, and all of that blood eventually has to go into the pulmonaries and into the lung. So that again is an example of an acyanotic heart disease. Why is it acyanotic? Because the shunting is happening from the left to the right. Okay, you don't have mixing of desaturated blood into the systemic circulation. So it's not a right to left shunt. Your VSD, PDA, and ASD, all these three will only have a left to right shunt initially. We're not talking about complications that when you have a long-standing large VSD, eventually it leads to isomanganization and reversal of shunt. I'm not going into those details yet, but if you're talking about a plain simple VSD, the shunting is always going to be left to right, which results in more blood volume into the right ventricle, which eventually has to enter the pulmonary arteries. And that is what is called as increased pulmonary blood flow. Okay, so this is what we were talking about when I said you can classify the acyanotic or the cyanotic on the basis of pulmonary blood flow. So remember, VSD, ASD, and PDA are all examples of acyanotic with increased pulmonary blood flow. Having understood this, let's look at what happens in the hemodynamics of a TOF, which is the best example of a cyanotic heart disease. So this is what a normal heart looks like, pretty simple to understand. This is what a heart in the tetralogy of Fallot looks like. So this is another question that can be asked, that what are the four components of the tetralogy of Fallot? Okay, tetralogy, as the name suggests, refers to four things. So there are four things that go wrong in a TOF. Okay, the first one being pulmonary stenosis. Okay, so there is stenosis in the pulmonary valve, which results in hypertrophy of the right ventricle. So if you can compare these two hearts, the right ventricle is way thicker and hypertrophied as compared to this diagram. The third one is that there is a large ventricular septal defect that's communicating between the RV and the LV. And last but not the least, you have overriding of aorta. So now let's look at each one of them as to why it happens and what it leads to. So the first thing that what happens in TOF is that this pulmonary stenosis. What does that mean? That there is a resistance to the outflow of blood from the right ventricle into the pulmonary artery. So basically there's less amount of blood which is able to exit the RV to enter the pulmonaries. But now where does all this amount of blood go? Okay, there has to be an exit route for the blood that's entering the RV. So an easier way is going to be through the VSD. So all the blood that enters the RV, because it's not able to cross the pulmonary valve because of the pulmonary stenosis, and there is an easy way out here. This is the path of least resistance, as a result of which blood starts shunting from the right ventricle into the left ventricle across the VSD. And this is known as a right to left shunt. Okay, so you have mixing of the deoxygenated, desaturated blood from the right ventricle into the left ventricle via the VSD. So this VSD in a TOF is shunting from right to left. Okay, so you have mixing of blood. And at the same time, what does overriding of aorta mean? So normally the aorta tends to sit over the LV because the aorta in a normal heart only receives output from the left ventricle. But because of the anatomy and the structure in a TOF, what happens is now the aorta sits over both the RV and the LV. So what happens is all the blood that's shunting across the VSD from the RV into the LV directly enters the aorta. So basically the aorta now gets desaturated blood that does not have a chance to go to the pulmonary artery for oxygenation. And that is a result of which you see cyanosis in a case of TOF. So cyanosis happens because you have shunting of deoxygenated blood from the right ventricle into the left ventricle via the VSD. And you have that same blood which is now entering the aorta and into the systemic circulation. And why is TOF an example of a cyanotic heart disease with decreased pulmonary blood flow? That's because of the pulmonary stenosis. Okay, so there is decreased amount of blood that can exit the RV to enter the pulmonary arteries. And as the name suggests, it results in decreased blood flow into the pulmonary arteries. So it's an example of cyanotic heart disease with decreased pulmonary blood flow. I hope these concepts are clear as to what happens in the hemodynamics of a VSD and what happens to the hemodynamics of a TOF. Keeping these concepts in mind, let's look at what happens in an acyanotic CHD. So what are the common presenting complaints in an acyanotic heart disease? So first one is signs of congestive, or I would rather say symptoms of congestive cardiac failure. So you've heard these terms very, very often: forehead sweating and suck rest suck cycle. So both of these terms, what do they mean or what do they signify? Forehead sweating with suck rest suck cycle are both indicative of congestive cardiac failure. Along with that, they can also have rapid breathing when the child is supine, and the child feels a lot better when held vertical against the shoulder. So you will often get this kind of history from the informant or from the mother that the child is tachypneic, has rapid breathing when the child is kept on the bed. But the moment I take him on the shoulder and hold him vertical, he or she is a lot better. Other than that, they also have signs of cough and recurrent lower respiratory tract infection or recurrent pneumonias. So that presents with hurried breathing and chest retractions. The third one being when they have chronic long-standing CCF, they can have failure to thrive, decreased urine output, oliguria. And last but not the least, often mothers present with complaints of increased precordial activity that occurs because of a hyperdynamic circulation. Now, let's look at why each of these things happen, and all of these questions are potential viva questions. That what is the significance of suck rest suck cycle? Why do you get forehead sweating? Why do these kids get recurrent LRTI? Why do they have failure to thrive? So let's look at each one in detail. So what exactly is a suck rest suck cycle? So remember, Feeding in infants is a form of an exercise. It's basically causing a lot of exertion in them. What happens in suck-rest-suck cycle? As the name suggests, suck, rest, and then suck. So what happens is the child suckles at the breast for some time. Then the child gets tired, okay, and rests or goes off to sleep. But then the child realizes that, I've not consumed as much milk as I should have. My tummy is not full yet. And the child wakes up again, feeds for a little while, gets tired, goes off to sleep, and then again gets up and feeds. So this cycle, or this vicious cycle of feeding inadequately, resting for a while, waking up thinking that, oh, I'm still hungry, again feeding for a little while, again resting, going off to sleep, and waking up. This cycle is known as the suck, rest, suck cycle. Now, having understood what it is, why do you see suck, rest, suck cycle in an acyanotic heart disease? So what happens, like I said, feeding is a form of an exertion. Okay, so feeding results in exercise, increased exertion, that results in increased sympathetic activity. Okay, so you have tachycardia and tachypnea. But because you have an underlying CHD, the heart basically is not able to keep up with the increased demands that you need to accomplish with the breastfeeding. So because the heart is not able to keep up, the heart is failing. And that is the result why the child feels tired. He feels he needs to rest for a little while, and then he starts feeding again. Okay, so it's basically because the heart is failing, there's congestive cardiac failure, and the heart is not able to keep up with the increased oxygen demand that is caused by the breastfeeding, which is a form of an exercise. The child takes a lot of breaks while feeding. Why do you have forehead sweating along with suck-rest-suck cycle? So again, sucking, which is a form of an exercise, stimulates sympathetic activity. So when you have sympathetic stimulation, it results in increased production of catecholamines and cortisol. That increased catecholamine results in tachycardia, tachypnea, and along with that, you have diaphoresis or forehead sweating while feeding. So the reason for both of this is basically sympathetic overstimulation, which results in increased work on the heart, but because the heart has an underlying defect, it's not able to keep up with the increased demands, and that is a result of which you have the suck-rest-suck cycle and forehead sweating. So both these things together signify that there is cardiac failure. So these are questions that can be asked you, that what is the meaning of SRS cycle and why do you get forehead sweating? I hope this concept is clear. If not, you can ask me questions at the end and we can discuss this once again. Now, another thing that they commonly complain, or another common issue, is they have recurrent lower respiratory tract infections. Now, what is the definition of recurrent LRTI? So when they have 2 or more episodes of pneumonia, okay, mind it has to be LRTI or it has to be pneumonia. It cannot be an upper respiratory tract infection. And usually they require hospitalization for this. So when they have more than 2 episodes of LRTI in a year, or if they have 3 or more episodes ever in the lifetime, then this is the definition of when you categorize the patient as having recurrent LRTI. Now, it's important to know that to be able to differentiate it from persistent pneumonia, ideally, there should be radiological clearance in between those 2 episodes of LRTI. But obviously, this is not some kind of history that the mother is going to give you, right? That she is not going to know about the radiological clearance. But if the child was apparently all right in between those 2 episodes, doing well, then you can consider them as 2 episodes separately and not like a persistent pneumonia. Okay, so this is a definition of recurrent LRTI, again, that can be asked in your vivas. The next question is going to be, why do these kids develop recurrent respiratory tract infections? So first thing is, when you have a left to right shunt, we already saw that it results in increased pulmonary blood flow. So there's more amount of blood that's now exiting your pulmonary arteries. That results in dilatation and engorgement of your pulmonary arteries. Now, when that dilates, it presses onto the adjacent smaller airways in your lungs, resulting in microatelectasis. And when you have microatelectasis, these areas serve as a nidus for infection that can then predispose these kids to recurrent infections. So that's the number 1 mechanism. Point number 2, when you have increased pulmonary blood flow, okay, all that extra amount of fluid tends to seep from the capillaries into the interstitial space. Okay, so you have interstitial edema or interstitial fluid overload. Now that results in your lymphatic stagnation, stasis of fluid, okay, and that fluid again can serve as an nidus for infection and result in repeated pneumonias. Point number 3, when you have increased pulmonary blood flow, it results in your goblet cell hypertrophy and there's increased mucus production. At the same time, when you have impaired ciliary function and impaired ability to get rid of that extra mucus, it results in mucus plugging, which again results in your atelectasis, closure of your airways, which serves as an infection source and can result in repeated pneumonias. Last but not the least, these kids can also have nutritional deficiency. So we just saw that they have suck cycle, feeding difficulties, forehead sweating. So a lot of times their alimentation and feeding in these kids is impaired. So they have nutritional deficiencies to add to the other 4 problems that we just discussed. So that is the reason why these kids have or are at a risk of having recurrent lower respiratory tract infections. Again, these are questions that can be asked: why are they at a higher risk? So it's because of these reasons. So if you have to blame all of this to one thing, it's all because of the increased pulmonary blood flow, which is then leading to these set of complications causing recurrent pneumonias. The third one is, a lot of times these mothers will also complain that even at rest, the child has rapid breathing. Okay, now why does that happen? Now we saw that there is increased pulmonary blood flow, right? So all of that blood eventually has to return into the left atrium, into the left ventricle to exit across the aorta. So when that extra amount of blood which exited the right ventricle, okay, enters the pulmonary, gets oxygenated and comes back to the left ventricle. So there's increased pressure in the left ventricle, right? So there's increased left ventricular and diastolic pressure. So when you have increased pressure in the left ventricle, that pressure starts getting transmitted backwards. So your LA pressure increases, your pulmonary venous pressure increases. When you have increase in the pulmonary venous pressure, it results in diffuse interstitial edema, or what we commonly refer to as pulmonary edema. So when you have pulmonary edema, what happens is that the lungs become very stiff, they become rigid, they lose their elasticity. What happens then is there's activation of the J receptors in the lungs. Now, J receptors are located on the alveoli adjacent to the capillaries. So when the capillaries and the interstitium become full of fluid and they become distended, dilated, the J receptors get activated. When you have activation of the J receptors, it results in the Hering-Brewer reflex. Now, what is that? So Hering-Brewer reflex is basically a protective mechanism to prevent hyperinflation of lungs. So when you have activation of J receptors, your Hering-Brewer reflex gets activated. So the lung or the body now senses that I am not supposed to let the lungs hyperinflate. So in order to maintain the saturation, maintain the oxygenation without causing lung hyperinflation, what is the other way it can do it? It's going to cause rapid rate of respiration, fast breathing, and along with the rate, it is also going to activate your accessory muscles of respiration. So it could be your subcostal retractions, intercostal retractions, flaring of ala nasi. All of this starts happening to be able to compensate for this interstitial edema. So this is the reason why if you see a lot of kids with CHDs have baseline tachypnea, and they normally have a slightly higher rate of respiration as compared to those who don't have a CHD. So this is the reason why you get rapid respiration in an acyanotic CHD. I hope this is clear. Last but not the least, why do these kids have failure to thrive? Okay, so 3 main reasons is, number 1, like we saw, they have feeding difficulties in suck cycle, and that's a result of which their nutrition gets impaired. CHDs have an inherent increased catabolism rate. Okay, so their catabolism is more than their anabolism, and that's the reason why they tend to lose weight, and they tend to not gain as much weight as a kid who doesn't have a CHD does. And lastly, because they have repeated LRTIs, they have repeated illnesses and repeated hospitalization. So again, that overall has an impact on the nutrition and the immunity. So that is the reason why you often see failure to thrive in kids who have long-standing CHDs. Again, a lot of it can be blamed to the underlying congestive cardiac failure. Okay, so we saw this. These were the common symptoms of a CHD or an acyanotic CHD. Now, what are the signs of CCF? So we saw symptoms on examination. These kids will have tachycardia, respiratory distress in the form of increased rate of respiration, presence of intercostal and subcostal retractions, tender hepatomegaly. So they will have an enlarged liver on palpation and it will be painful because of congestion. Dependent edema. Now remember, infants, in infants, the legs are not the dependent part of the body because they are lying supine. The dependent portions becomes the sacrum and the, so they present more with abdominal distension and sacral edema. So when you have to look at a dependent edema in infants, these are the two places that you look for. And lastly, if it's an older child, raised JVP can also signify the presence of a CCF. So remember, if you have in your history, if you have the history of saying the child has recurrent pneumonias or recurrent LRTIs requiring multiple admissions, at the same time, he has failure to thrive, and the mother also gives you a history of suck cycle. All of these signify that this is a lesion with an increased pulmonary blood flow. And that is why it is important to know what pulmonary blood flow means. Why is it increased pulmonary blood flow? And if you have your history taken from your informant, and if you're talking about increased pulmonary blood flow, you need to keep in mind when you have this history and this presentation. Moving ahead, like you use the NYHA classification for heart failure in adults, we use the modified Ross heart failure classification in kids. So it's pretty much similar, but till about 7 to 10 years of age, you should mention that these are the kind of symptoms that the patient has, and hence I can 3 or 4 of heart failure for this particular patient. So he is usually asymptomatic to have in an older child. Class 3 is marked tachypnea or diaphoresis on feeding or exertion. In class 4 is symptoms even at rest. So this is known as modified Ross heart failure classification that is supposed to be used in kids up to at least 7 years of age. Now, having looked at the common presentation and common terminologies that we use in an acyanotic CHD, now let's see at what happens in a cyanotic heart disease. So what is the meaning of cyanosis? Cyanosis basically refers to bluish discoloration of tissues, and that happens when you have an increased concentration of your deoxygenated hemoglobin in your capillaries. So this is the reason behind cyanosis. Now, cyanosis can be categorized again as central or peripheral. Now, it's very important when we are dealing with a cyanotic CHD is central cyanosis, peripheral cyanosis. So central cyanosis happens because there's reduced oxygen, arterial oxygen saturation, which happens either because there is a defect in the oxygenation in the lungs or there's mixing of your arterial and your venous blood. Now, next, cyanosis, if you're saying central cyanosis. So always say tongue and oral mucosa. Tend to avoid saying lips because lips sometimes lip cyanosis can also be seen in peripheral cyanosis. So whenever you're trying to look for central cyanosis, always look at your tongue and oral mucosa. Other than that, otherwise in a central cyanosis, you'll have warm peripheries. The perfusion is good, so CRT will be less than 3 seconds. It is often associated with clubbing. And common conditions where you will see central cyanosis could be categorized as cardiac, respiratory, or others. So in cardiac, you can have most commonly in cyanotic CHD, so your T series. Another common cardiac condition where you can see central cyanosis is when you have acyanotic CHDs with Eisenmengerization. What is Eisenmengerization? Ideally or initially in a VSD, like we discussed, you will have a left to right shunt. But when you have a long treated ventricular septal defect and the pressure hemodynamics change, what happens is then the shunt starts flowing from the right to left. So the same VSD which was initially shunting left to right now becomes right to left, and that results in cyanosis. So that is what is called as an acyanotic CHD with isomangarization or reversal of respiratory conditions like RDS, pneumonia, cystic fibrosis, BPD can also result in or can also present with central cyanosis. Other common conditions could be the methemoglobinemia or carbon monoxide poisoning. So this is the understanding behind central cyanosis and common conditions where you will see it. And always remember, you will look for the tongue and the oral mucosa for the presence of central cyanosis. Whereas peripheral cyanosis, on the other hand, has normal arterial oxygen saturation, but you see cyanosis because there's increased extraction of tissues from the peripheral tissues because of sluggish blood flow. So because you have sluggish blood flow, there's going to be impaired perfusion. So you will have cold peripheries. The perfusion is going to be delayed. So CRT will be cyanosis. So conditions where you see peripheral cyanosis, basically shock, decreased cardiac output, and local vasoconstriction. So this is the difference between we asked you in your vivas, that where do you look for cyanosis? What are the examples of central and peripheral? So that is why it's very important to know this. Now, having discussed that, you can see that this child has central cyanosis because if you look at the tongue, it looks blue. Okay, on the other hand, this is a neonate where otherwise the center is looking very pink. It's just that the extremities are looking bluish. Okay, this is what is called as acrocyanosis, very commonly seen in the newborns. So they will have cyanosis of the peripheries, but at the same time, if you look at their saturation, it's going to be normal and they will do well otherwise. Acrocyanosis impaired autonomic stability in newborns, and as the newborn grows, they tend to outgrow this acrocyanosis. So this is the difference between central and peripheral cyanosis. Also in the central cyanosis, this kid also has clubbing. So that again adds on to the fact that yes, this points more towards the presence of a central cyanosis. So what are the common presenting complaints in the cyanotic CHD? They usually present with cyanosis or cyanotic spells, squatting, or breathlessness. Now, what is the cyanotic spell? What is squatting and why do you get this? This is again a diagrammatic representation of what a TOF heart looks like. So just to go over it again quickly, you have four components. You have pulmonary stenosis, you have right ventricular hypertrophy, you have a large VSD, and you have overriding of the aorta. So what is a cyanotic spell? So cyanotic spell occurs in a cyanotic CHD with a peak incidence between about 2 to 6 months of age. Now, why do you get this cyanotic spell? So remember, any kind of exertional activity, it may be crying, feeding, defecation, or any other kind of exertion. When you have this, it results in sympathetic stimulation. That stimulation results in tachypnea or hyperapnea. So the child tends to have rapid rate of respiration. When you have this, or when you have sympathetic stimulation, along with hyperapnea, you will also have increased in the heart rate. And along with that, you will have increased cardiac output. So there's more amount of blood that's now leaving the left ventricle to enter the systemic circulation. When you have more cardiac output, eventually all of that blood has to come back to the heart, right? So there's going to be increased venous return to the right side of the heart. So now what happens? When you have increased systemic venous return, that results in more shunting from the right to left across the VSD. So if you look at this diagram to understand this better, well, I said there is going to be more cardiac output. Okay, so there's more amount of blood leaving the heart. All of that blood eventually has to come back to the right side. So now there's more amount of blood that's entering the right atrium, right ventricle. But because we know that there is a fixed pulmonary stenosis over here, this door is shut. But that blood has to exit the right ventricle somehow, right? So now what happens is all the blood from the right ventricle, because this door is shut, starts shunting across the VSD as right to left shunt from the RV into the LV to eventually then exit back into the aorta. So what happens is the blood is not able to go to the pulmonary arteries for oxygenation. It is directly getting shunted from the right to left and again entering the systemic circulation. So increased venous return causes increased shunting of blood from the right to left across the VSD. All of that blood eventually exits the aorta, so that results in systemic desaturation. Worsening of cyanosis. When you have worsening of cyanosis, you will have decreased in the PO2 and increased in the PCO2. Now the body senses that, oh, there is more carbon dioxide in the body, so I need to flush it out. And how do you do that? By hyperventilation. So that increase in PCO2 again stimulates your hyperapnea. And this vicious cycle continues until something is done to stop or abort this cyanotic spell. So this is the pathology and understanding of why you have a cyanotic spell in a cyanotic CHD with decreased pulmonary blood flow. So we've all heard that TOF results in cyanotic spell. So many a times a kid presents with the first episode of cyanotic spell. So the mother will say that probably he was crying a lot and he suddenly turned blue. Right. So this is what happens, or this is the pathophysiology of the cycle of a cyanotic spell. Now, having understood this, we all know that squatting helps to abort a cyanotic spell, and it's the first thing that you do when you see a child going into spell. So how does squatting help? This is an example of what squatting looks like, right? So when you sit in this position, it results in a compression of the femoral artery and the femoral vein. Okay. So what happens because of that? When you have compression of your femoral vein, it results in decreased venous return to the right side of the heart, correct? And at the same time, when you have compression of the femoral artery, when your femoral artery gets compressed, you have increase in your systemic venous return. So basically, to simplify that, or to say it in a easy to understand language, when you're sitting in the squatting position and there's compression of the femoral artery, the blood pressure increases. Okay, and that blood pressure tends to backtrack and increase pressure in the left ventricle. So you have decreased venous return to the right side and increased pressure of the left ventricle. So what happens because of that? Because you have decreased venous return, there is less amount of blood that is available to shunt from the right to the left. Secondly, because you have increase in the systemic venous return and your LV pressures have increased, again, there is going to be a decrease in shunting across the right to the left because the LV pressure is high, right? So what happens is there is decrease in the desaturated blood from the legs entering the heart. At the same time, as the SVR increases and the LV pressure increases, there's decreased right to left shunting across the VSD. And now more blood enters the pulmonary arteries from the right ventricle. So more amount of blood can actually go to the lungs for oxygenation, and that will help in decreasing your cyanosis. This is the mechanism of squatting and how squatting helps to abort a cyanotic spell. This is something, again, which is very important to understand. And again, some kind of question that can be asked in Viva, that how does squatting help in a cyanotic spell? Having understood this, there are certain positions that are known to be squatting equivalents. Okay, so this is the first, that sitting down with the legs drawn underneath, or sitting on a chair with the legs drawn underneath, or standing with the legs crossed, or a mother holding the child with the legs drawn or flexed under the abdomen. So in all of these positions, it's the concept is the same, that there's compression of the femoral artery and the femoral vein, which results in helping to abort a cyanotic spell. So what happens is, initially these infants present with spells, and the incidence of these cyanotic spells tends to decrease by the time they're about 2 to 3 years of age. And then what happens is that the child is able to anticipate that, I'm having difficulty in breathing, and probably there is going to be a cyanotic spell. And what happens is the incidence of spell reduces because the kids are able to adapt this position on their own. Okay, so if you've seen in your wards, if you have an older child, say with TOF, they often adapt this squatting posture on their own before actually developing a cyanotic spell. So these are known as squatting equivalents, and something that is seen more commonly in the older in the older children, probably more than 3 to 4 years of age, who have an underlying cyanotic CHD. Having said that, this is the gist of what you see in a cyanotic CHD. So why you have cyanosis, what is a cyanotic spell, what is squatting, is something that we've just discussed. Now, just a last few slides as to why is the age of presentation of cardiac symptoms so important. So I'm going to be asking you two questions. The first one being, TOF always presents with cyanosis at birth. Is this true or false? And the second question is that a large VSD usually presents at 4 to 6 weeks of age. Yeah. So what is the answer to the first question? Does TOF always present with cyanosis at birth? So I'm going to be giving you the answer this time. The answer is no. The second question is, a large VSD presents at 4 to 6 weeks of age. Is the answer true or false? It's true. Now, why is it so important for us to know at what age did these cardiac symptoms start appearing? That is because you have different CHDs presenting at different times of life. Okay, so if you have a CHD that's presenting in the first week of life, you have to think of duct dependent lesions. Now, what duct am I referring to? I'm referring to the ductus arteriosus, or the PDA, the patent ductus arteriosus. So when you have certain critical congenital heart diseases, the patient or the kid will only be able to survive if the ductus arteriosus remains patent. Okay, so those conditions that present within the first 1 week of life, either with severe cyanosis or with shock, you need to think in terms of duct dependent lesions like severe coarctation of aorta, severe aortic stenosis, or severe pulmonary stenosis. How do you pick up these duct dependent lesions? Is with the help of something known as CCHD screening, which is known as critical congenital heart disease screening. Don't worry, don't get confused. We'll see this as we discuss the case presentation of a cyanotic and an acyanotic heart disease. But to just keep that in mind, we really are interested in picking up these critical CHDs as early as possible, because as the term suggests, they are critical. So they will not give us too much time to act. And that is why these conditions will present well within the first 1 week of life. Whereas those conditions that present between 1 to 4 weeks of life, you need to think of the T series like TGA, TAPVC, truncus and tricuspid, but remember, not TOF. TOF usually presents at about 4 to 6 months of age. Now, there's a reason why you will not see TOF commonly presenting this early as the other T series are. But why does a TOF not present so early? We'll look at that when we discuss TOF in detail. If you have a large VSD or a large PDA, they usually present at about 4 to 6 weeks of age. Now, there is a reason also why these lesions present at this particular age, and we'll be seeing that in the following discussions. A lot of times when you have an ASD or a small VSD or a small PDA, they might go unnoticed because they're asymptomatic, or they might be detected incidentally. So this is the reason why you need to know what age of presentation did these cardiac symptoms start appearing first. And that age will be able to tell you that, okay, you're dealing with probably this kind of a heart disease. Having said that, if you just take an example of TOF, it doesn't mean that a TOF cannot present at birth. It can present if if your pulmonary stenosis is so severe that there is almost absolutely no amount of blood that's able to enter the pulmonary arteries from the right ventricle. These patients can present with cyanosis even as early as probably 4 weeks of life. But if you're looking at TOF on a broader aspect, usually TOFs present at about 4 to 6 months of age. So it's not that TOF cannot present at birth. I'm not saying that, but commonly, if you look at a commoner presentation, TOF usually presents at 4 to 6 months of age. This is the significance of the age of presentation and what differential diagnosis you probably are dealing with. So just to summarize, at the end of history taking, when you're done with all the domains in terms of your chief complaints, HOPI, your antenatal birth history, immunization, this, that, etc. How do you summarize it? So you will see that this is a case of probably, a congenital heart disease, either cyanotic or acyanotic, depending on what your chief complaints and your symptoms are. increased or decreased pulmonary blood flow. So we just saw that. So if you have somebody who's presenting with CCF, recurrent LRTIs, that means you're dealing with increased pulmonary blood flow. At the same time, if you're dealing with somebody who's having recurrent cyanotic spells, then you're dealing with a decreased pulmonary blood flow. Left to right or right to left shunt, depending on whether you have cyanosis or you don't. And then having said that, you will now be able to, if we go back to the first classification, you will now be able to categorize them either as cyanotic or acyanotic, either as increased or decreased pulmonary blood flow, depending on your history taking. So this is only on the basis of history. We have not really gone into examination yet, but now you'll be able to summarize your case as falling into either one of these 4 categories. So that is how you summarize your case at the end of history taking. We will take history taking in CHD in a different case, in a different discussion together. But the reason for taking this class was just to get your concepts about approach to a CHD and common terminologies that we use, like increased blood flow, cyanotic spells, what is squatting, what is forehead sweating, suck rest suck cycle. All of these things that we have discussed today are all potential questions that can be asked to you in your vivas as to why do you see this, what does it signify, etc., etc. So I hope you guys have understood what you've discussed today, and that is the end of my talk. Now it's time for questions. So if you guys have any questions, you can start. Okay, so somebody is asking, why does TOF present at 4 to 6 months of age? There is an entire reason, and there are about 4 reasons as to why it doesn't present at birth. And don't worry, I'm not going to leave this question unanswered. I'm just leaving it for the time when we do a case presentation on TOF separately, because there are a lot of other concepts in TOF that you must remember, other than the fact as to why does it not present earlier or why it presents at 4 to 6 months of age. So I will be covering that, but in the TOF discussion. Does anybody have any other questions that you guys want to ask? Yeah, before we end the session, there is a feedback form that there's a link for the feedback form in the chat box. So I think you guys need to enter your name, email address, and a short feedback on how you like the class, any kind of improvisations. I am open to suggestions. So if you guys have any suggestions, if you guys want me to change some particular way of explanation, teaching, or something, I am more than happy to take your suggestions positively. So let me know. Okay, somebody is asking, can you explain why the tachypnea eases when the mother lifts the child on the shoulder? Okay, so basically this, if you have to compare this with probably an older child or an adolescent or even an adult, it's similar to orthopnea. Okay, so probably when the child is lying flat, the child becomes breathless, and at the same time, when the child is made vertical or made to be held vertical against the shoulder, the tachypnea decreases. Why does this happen? It's very similar to orthopnea. So basically, you have more pulmonary edema when the child is lying supine. Okay, so there is more extravasation of fluid into the interstitial space. There's more pulmonary edema. Whereas when the child is held vertical, that decreases, as a result of which the breathlessness and tachypnea decreases and the child feels much better. So it is your positional tachypnea is similar to orthopnea in an adult. I hope that answers your question. Okay, do we have any other questions? I want you guys to really understand these concepts of terminologies that we've discussed today, because once you understand this, the following discussions, so I'll be taking one class on case presentation of an acyanotic heart disease, and where we'll discuss the history taking and examination and the viva questions, and another session where we discuss TOF or a cyanotic CHD, again in the same order of history taking, examination, and viva questions. If you have understood today's concepts well, then the next 2 sessions are going to be really easy to understand. You'll be able to actually grasp things a lot better, and you will not have any doubts for sure. So I hope you've understood today's sessions and understood these concepts. Okay, someone's asking how hyperapnea increases venous return. Okay. So when you have hyperapnea, along with hyperapnea, you also have increased heart rate and cardiac output. That happens because you have increased sympathetic overstimulation. So when you have increased sympathetic activity, increased catecholamines, you will have increased tachycardia, tachypnea, and increased cardiac output. So that cardiac output which goes out eventually has to come back. So when you have increased cardiac output, you will have increased venous return to the heart, because basically all the blood that exits eventually has to come back to the heart, right? So that is the reason why you have increased cardiac output when there's any kind of exertion because of sympathetic overstimulation. Is that clear? Okay, so any other questions, or we can end this session? Okay, awesome. I don't see any more questions in the chat box. I hope you guys have understood. I would probably recommend that before we take the next discussion on individual case presentations, go through the slides again. You have these presentations with you now, so you can use it for your reference forever whenever you want to refer to them for revision or before your exams. Go through these concepts once again. If you have any questions, we can discuss this in the next class again. Or if you understand these concepts well today and you go over them and revise them again, like I said, the following case discussions are going to be way easier and way more fun. It'll be way more interactive because at that time I'm going to be throwing a lot of questions, and it's going to be more interactive. Today's session was more theory and more concepts, so that's the reason why I was the one talking more. But the next few sessions are I think all sessions are going to be more interactive. So I request you guys to go over these slides once again, and I will see you on the next class. Okay, someone's asking, ma'am, how does compression of femoral result in increased SVR? Okay. So basically in this squatting position, when your femoral artery gets compressed, so your femoral artery is basically a branch of your aorta. Okay, so what happens, femoral artery gets compressed, and that back pressure or that increased pressure goes on getting transmitted backwards. So your femoral artery pressure increases, your aorta pressure increases, as a result of which your LV pressure increases. So that's the reason why you have increased systemic vascular resistance, or basically increased blood pressure. It all starts with the fact that you have compression of the femoral artery and the pressure gets transmitted backwards. Can you please share the PowerPoint? Yeah, I will share it. I actually did share. Okay, I can do that again. Why suck cycle and forehead sweating is not seen in a cyanotic heart disease? So suck cycle, if I go back to the slide. Okay, so suck cycle and forehead sweating are both signs of congestive cardiac failure. They can also happen in a cyanotic heart disease, but it has to be a cyanotic heart disease with increased pulmonary blood flow. Okay, so when I'm talking about when I'm talking about suck cycle and forehead sweating, both of these signify CCF because of increased pulmonary blood flow. So it can happen in both the conditions. Why I didn't mention it under the category of cyanotic, because I was talking about it more in terms of TOF, because that is the most common cyanotic CHD that we encounter. And TOF is an example of a cyanotic CHD with decreased pulmonary blood flow. So here you will see cyanotic spells. But if you have a cyanotic heart disease with increased pulmonary blood flow, probably a TGA or a TAPVC or truncus, then you can have these symptoms of suck cycle, forehead sweating along with cyanosis. So it's not that you will not see these signs in a cyanotic heart disease, just that you will see it under the category of cyanotic with increased pulmonary blood flow, and you will not see this in TOF. Yeah. Okay, so let's end this session, and I hope to see you guys on the next session. where we will discuss case presentation on an acyanotic heart disease.